Thanks for staying here. Now we will come to the second part of the lecture on bone. And of course this lecture is not only about cortical bone. In the break I have received a few questions which I will address now in the second part of the lecture. We have been talking about osteonal bone. I mentioned that osteonal bone is the bone out of which all of our long bones and bones exist as long as we are adult. So the osteonal bone contains those lengthy osteons which can have up to a length of 40 centimeters, depending of course in which bone we are. So this osteonal bone is a highly structured bone. It can be highly mineralized, and there's a very, very good ratio between weight and performance. This ratio between weight and performance is in general very important for bone, because we want light bones, because we have to carry them around with us every day, every step. We have to carry all of our bones. And if our bones are too heavy for one reason or another, of course this will be not effective. It will consume too much energy, and therefore our bones tend to remodel, and when they remodel, they're always changing the shape into the direction of an optimization. This is important to understand, that bone, when it remodels, usually shows a smaller amount of bone at the end of the remodeling process. That's why when we place implants, we have to expect that after this operation, after the healing is done, after the osteonal remodeling has come to a standstill, there will be less bone than before. Usually bones are growing while we are growing in the age, especially between 10 and 20 years of age, when we gain most of our height, then the bones are growing. This process is induced by hormones and of course by function. It's directed by function, but typically at the end of the growth we have too much bone, so that in the following process of remodeling we are going to lose bone. Of course we lose more bone in the jaw bones than in our long bones, because in our long bones we need the amount of bone. There's not such a lot of bone which is not necessary and could be remodeled away. But in the jaw bones we can lose a lot of bone, especially after the teeth are extracted. We call this process atrophy, and atrophy means that there is nothing to eat, there's no nutrition for the bone. Now we've been talking about osteonal bone, and in the second part of the lecture I want to come to the callus and the woven bone. Callus is a complex tissue formed at the site of bony repair. Following a fracture, it goes under gradual progressive transition through a series of tissue types. So callus is formed out of the blood, out of the hematoma. The next step is granulation tissue, then fibrous tissue, and finally calcified tissue. And the tissue in the woven bone can be quite strong, but this is due to the quantity of the bone. As osteonal bone is very well structured, we don't need a lot of cortical bone and osteonal bone to perform, but we need a lot of callus to come to the same performance. And that's why we have, when our legs or arms are fractured, that's why we have a big swelling, and this swelling is going to remain for quite a time. This swelling is nothing else than woven bone, and this woven bone simply requires a lot of space. The question whether we can have a woven bone formation in the vicinity of two-stage implants is a very interesting question. Of course, we don't have a lot of space in the vicinity of two-stage implants, because having space would conflict with the idea of primary stability. So if a two-stage implant is placed into the bone, of course we expect that there will be a kind of biologic osseointegration, and for this biologic osseointegration we need blood, we need granulation tissue, fibrous tissue, and so on. In other words, we expect that some woven bone would develop there, but this woven bone requires space, and typically the implantologists would not allow that space is in the vicinity of a dental implant. The formation of callus can also be the sign for unexpected mechanical instability. So this is, for example, the case in an irritation callus. This graph shows that callus forms in the gap area between the fractured bone sides. There's an endosteel bone formation, endosteel callus formation, and a peristeel callus formation. And the peristeel callus formation is not as important for the survival of the callus. The endosteel bone formation, the inside these fracture areas, is by far more important than the peristeel bone formation. Because if there's no endosteel callus, we will usually end up in a non-union, and the process has to be started again. Typically we see that after 4, 5, 6 weeks of callus formation, the stability increases, and the interfragmentary movement, this is the red line on this picture, the interfragmentary movement goes down to 0, and this is what the callus is made for. The callus will give stability to the bone, to fractured bone areas within a very short period, typically between 6 and 24 months, depending on the site. On this graph, different sites are mentioned, so we see that the ribs and the clavicular and also the mandible have a very short healing time. So after 4 weeks we can expect some stability inside a fractured mandible. For example, the femoral neck with 24 weeks healing time, or the tibia shaft with 18 weeks. It's a completely different story. In general, you can say that the warmer the limb is and the more closer to the center of the body, the faster the healing takes place. Now on this histology, you see a basal implant, a lateral basal implant inserted in a rabbit tibia after probably 2 months. As you can see, there are no changes in the second cortical, so you don't see any remodeling here, but you see a lot of callus formation on the insertion site. You see also callus formation on this part of the insertion site. You see mottled bone. This bone is of peristeel origin. Inside this hollow bone, of course, we see a lot of fat. So this is what we can expect if a lateral basal implant is placed into the bone. There will be almost no reaction in the second cortical, but there's a lot of reaction in the first cortical. And of course, the first cortical is the cortical which is affected most, because there we really have a penetration of this instrument creating the osteotomy into the center of the bone. Sometimes I get the question, aren't there any single osteoclasts, or aren't there any single osteoblasts? Because the idea of two-stage implantology, the idea of all these surfaces is that the implant surface has to be bone friendly. So you see all these advertisings. I think the worst advertising is from this Cell Plus surface, which is sold by a big company. And there you see the osteoblasts on the implant surface. I mean, a microscopic picture of the osteoblast on the implant surface. And then this osteoblast kind of with this dendrites is covering the whole surface, and then they write something underneath, this is so bone friendly. This is like, it's like on the Copacabana. Now, of course, this picture has nothing to do with the reality, because there are no single osteoblasts traveling through the bone. How could they travel through the bone? Because the bone is a hard tissue. It's as solid as the wall or as the ceiling of this building. There's no way that an osteoblast just picks up the suitcase and walks through the bone towards the beautiful implant site. So it's not possible that these kind of that these things happen as they are shown on these pictures. But unfortunately, most of the dentists will never understand that these pictures are just fake. On the other hand, single osteoclasts can travel, because they have the possibility to resorb bone, to destroy bone, and to make their way free. And I'm showing you a picture here, and we call these osteoclasts killer osteoclasts. They are perforating a trabecular plate of 120 micrometers thickness. And this picture should make clear for you, to create an image in your brain what can happen if osteoclasts are set free, if they're really traveling free. The problem with the disease, I mean, it's a disease if this happens at a large scale, is that the bone gets weakened, and you will not see anything on the Hounsfield unit. There will be no changes. Simply, suddenly, the bone, especially the spines, are going to collapse in these patients. Now, the question is often raised: does the callus increase the stability of the implant? I already answered this question in a way by saying there is not a lot of space in the vicinity of the implant. There's only, of course, a small gap, a micro gap, a few hundredths of a millimeter. And if there should be a callus formation, of course, this could contribute to the stability of the implant. On the other hand, please keep in mind that it's not enough to have a gap there. You also need blood vessels which are going to supply the nutrition to this callus, which is going to supply the calcium and the phosphate and so on. And I don't think that the idea of the biologic osseointegration, as postulated by Mr. Brannemark, included that the bone is going to be resorbed, there are going to be lots of blood vessels, and out of the blood vessels the callus develops and so on. So I personally don't believe that there is a lot of gain of stability through the callus. And of course, I don't believe that the implant surface has any influence on this callus formation. It's true, however, if you have a rough implant surface, then the blood clot, if there should be a blood clot, and of course the blood clot, when it sets, it shrinks. This is a kind of polymerization process. Then the blood clot would adhere better to the implant surface. If the implant surface is rough, and if the implant surface is polished, then probably the blood clot would adhere more to the bone than to the implant. This of course is a fact which we can assume to be true. Now, as you see on this picture, we always have a kind of danger zone regarding the stability, because the osteonal bone stability is going down. We looked at this part of the curve when we were talking about the osteonal bone, and it takes some time until the callus stability goes up. So there is a danger zone, and in this danger zone we do not yet have a callus formation, I mean a mature callus formation, and we already have a loss of stability because the process of remodeling in the osteonal bone has started. So for this reason, I recommend basically to load the implants before this red curve goes down. So in the first 3-4 days, before the osteonal remodeling starts, we have very stable bone, and the bone has no pores, so these osteons have not been formed yet. So the maximum stability definitely is available immediately after the implant placement, and it takes then a long time, let's say at least half a year, probably a year, until we come back to the same stability. So this is the rationale behind immediate loading of dental implants. And whenever you have the possibility to load implants immediately, you are working in this short time zone, 3 days, maximum 4 days, better only 2 days, where you have the maximum stability, no osteonal remodeling, and then you don't have to depend on the callus. You're not depending on any surface features. You are simply depending on the stability of the bone, which is not yet under remodeling. So for me, this graph, which I'm showing you here, is most important for all implantologists, and it makes you understand why you should load implants immediately. Now, this danger zone can become longer in case that the callus is lost, if there is an infection, of course. We see this, let's say, frequently in traumatology, in orthopedic surgery, if an infection should occur. In our field, we don't see this too often because we don't see too many infections in the implant site in the oral field, because the local resistance is much higher compared, for example, to the tibia or to other long bones. We don't have so many problems with infection. If we should lose the callus, however, due to an infection, we have to clean the site. We have to take out all the avascular, contaminated, infected, or other undesirable tissues. And by creating a new bleeding, of course, we give a start point to a new callus formation. But in this case, as you can see here, the danger zone is longer. Now, having said all this, I want to show you a picture out of the Straumann advertising. You may know this picture. It's about the S-active surface. You see that this graph is quite similar to the graph which I have shown you just before. You see here, they call it secondary stability new bone. So what Straumann claims is that they can increase the speed of the callus formation, and of course it is not possible to increase the callus formation, so this graph is a fake. Simply the surface doesn't help. I'm mentioning this explicitly because I want to brainwash you a little bit about the real life situation. So of course it's not possible to speed up the bone. It's not possible to speed up woven bone formation, and therefore it's not possible to move the blue line from the dotted to the outline blue line. So simply it's not possible. What is true in this picture, however, is that the primary stability of the old bone is going down. So the green line is the same line as the red line in my graph, which I have just shown you. I'm showing you this picture also to make you aware how we are actually being fooled. Not only fooled by the implant manufacturers, but we are also being fooled unfortunately, by the universities who are teaching all this. And that's why I recommend that you look closely into the real bone situation, and then you don't have to believe stories like these. The next picture is a histology of a basal implant, a lateral basal implant. On this picture, I want to show you a few details and explain a little bit what is going to happen if you place an implant into the bone. So this implant has been inserted from the left to the right. You see the end of the base plate. The white bone or the light gray bone is the old bone. It's highly mineralized. And the darker bone, these are the new osteons. They are not as well mineralized. This is approximately 3.5 months after the operation. You see that there was a second cut upwards. This was done, of course, with these rotating cutters, and this second cut upwards was then corrected to downwards. And yes, you can see this gap, this upward gap, is also filled with osteonal bone. So there was woven bone, then later on the remodeling has been taking place and osteonal bone is now developing. The small little particles which you see here, these are residuals of the cut out bone. So obviously some bone which has been cut out has been left inside this cavity, and then it came embedded into the woven bone, and now it's embedded into the osteonal bone which is forming now. It's clearly visible that nothing happens with this bone, so this bone is not the origin of new bone formation. Now we are made to think that creating a bone augmentation kind of leads to a situation where the old bone, creates new bones. So the old bone makes kids, and then we have more bone. This is of course not true. The old bone is dead. Nothing brings it back to life. And the best that you can have in this situation is no infection. And this old bone is, of course, not producing any new bone. The new bone comes out of the woven bone either, or out of osteonal bone. And as mentioned before, osteonal bone will only develop inside bone. So it's not possible that osteons are traveling through the soft tissue. Osteons are only traveling through bone. The same actually is seen on the side, on the right side of this base plate here. These white particles here, this is bone which has been chipped off by the base plate, and this old bone is now trapped here. And this old bone will remain there until the end of the life of this animal, unless just by chance it is going to be remodeled by new osteonal bone. So this bone does not create any new bone. Of course, we have to ask then the question, why are we doing a bone augmentation? And is the theory of the bone augmentation, as we read it in the books and as we hear it from many lecturers, is it really true? And my answer to this, no, it's not true. There's no bone coming out of dead bone, just like dead people don't make kids. A similar picture from the same experiment. You see this line on top of this old osteonal bone is very sharp. Up here we see woven bone formation. This is mature woven bone, so it's a little bit mineralized. And through this through this woven bone, new osteons are traveling. You see a long osteon going up and down here. Of course, we don't know if it's going up or it's going down. We can't tell from the picture because it can be cut out from anywhere. What you see is also that the osteons down here in the old bone are more mature than the osteons up here in the woven bone. This is of course clear because, I mean, the reason is clear. The reason is that first in the gap woven bone has to develop and then later osteonal bone is going to form. Here you see a part of the implant. This is in the center of the bone, and actually the second part of the base plate is outside of the bone. You don't see it here. There's another enlarged picture out of the first picture, the first histology which I have shown you. So there are rests of bone debris from the osteotomy cutting, and these parts of the bone, these little augmentation parts, do not contribute to the new bone formation, and we can just be happy if they don't create infection. Because if they catch infection, if some bacteria would adhere to this, of course the whole callus would be destroyed, and we would have to start with new callus formation, with new bleeding. Now, sometimes I get the question: is it necessary to open a flap, or is it an advantage to open a flap? Is it necessary? Now, the answer is clear. Of course, we know from the experiments about the regional acceleratory phenomenon that whenever you are creating a flap in the bone, you are going to lose the spongious bone inside the bone. So this part of the bone here in the center is going to be dissolved. Why is it dissolved? The reason is when you raise the flap, the drainage of the bone goes away, and if there is no drainage, of course there will be a stasis inside the bone, and this stasis will lead to a change of the pH, and as a result, all the inside spongious bone is going to get lost. This will be restructured, of course, so after a number of months, 4 to 6 months, we will see again spongious bone inside the bone, but it takes time. So this tells us that if we raise a flap for an implant placement, we are very likely to destroy the inner part of the bone, not so much the outer part, but the inner part, and therefore my personal recommendation is to perform implant placements whenever possible without a flap. Now, looking at the osteoporosis again, I mentioned before the osteoporosis as an example of very strong osteonal remodeling without refilling. And I mentioned that in osteoporosis, the stability of the bone goes down because the elasticity is lacking. And on this picture you see the mineral content of different bones. So this is an elk antler, a cow femur, and the whale buller. So the cow femur, this is approximately the bone which also we have. So we have approximately in our bones a mineral content of 65%. There are bones, cortical bones, available in nature with less less mineral content, like the elk antler. Of course, immediately if you decrease the mineral content, the fracture resistance goes up and the elasticity changes. And you see the same thing on the other side for a whale buller. If you increase the mineral content, the fracture resistance goes down, and this is due. And then you have also changes in the elasticity. Now, osteoporotic bone is, as I mentioned, extremely good bone. The mineral content is quite high, and therefore the elasticity is lacking, and this is actually the problem. This is why in elderly people who suffer from this disease, you see severe fractures if they are overloading, if they are mechanically overloading the bone. And what you will see also is that the fracture occurs immediately. It occurs on the spot. It doesn't just come to a number of microfractures who then add up into the big fractures, but immediately you see the fracture of the whole bone. Now, often also the question is raised, can we underload bone, and how does it work with the overloading of the bone? Well, if you overload bone, if you constantly overloading bone, of course, the microcracks, the fractures are accumulating, and every microcrack leads to a local osteonal remodeling, so to the repair of the bone. And if this happens again and again and again, without that the bone has the chance to remineralize those osteons, you will end up in the fracture of the whole bone, the whole long bone. And now in America, they did, in the 60s of the last century, they tried to find out how to train a soldier as fast as possible to send him to the war early. So when these young men came to the army, they gave him all these machine guns and a lot of loads, and they made him walk. Of course, with every step that this soldier takes with all this load and the machine gun, there's going to happen a microcrack, one microcrack or two microcracks in his long bones. Now, because they were walking such a lot, and there was no chance to remineralize these osteons, these bone fractures, and typically they fractured after 6 weeks. So this is called the syndrome of the untrained soldiers, and I hope this answers your question. Of course, it's possible to overload also the implants, because if you are overloading implants, the same will happen around the implants. With every bite, you will get a microcrack, and this microcrack then must be remodeled, it must be repaired. And if there are too many microcracks, of course, the bone changes into a big Swiss cheese, and the implant becomes mobile. So it's the same principle, only that typically, I mean, in the normal patient, you will not see any fracture of the whole bone. You will see this fracture of the whole bone only in osteoporotic patients, and again in osteoporotic patients, if you see fractures of the jawbone after implant placement, you see them after 6 weeks, just like in the case of this American experiment with the untrained soldiers, the untrained soldier syndrome. Now this is regarding overload. So if there is too much overload, or if there is overload, remodeling takes place as a response to the multiple microcracks, to the multiple bone trauma. It leads usually to steroid loosening, because, of course, if the bone fractures or if the implant becomes mobile, there are no bacteria connected to this, because it's a sterile situation. It takes place inside the bone. On the other hand, there's an underload reaction. If there is not enough force on bone, if the bone is untrained, remodeling takes place because there's a stasis in the osteonal transport systems. This also leads to a porosity and to a decrease in mineralization. The reason, the rationale behind this, why this happens, is that the transport of the liquids inside the osteons is not taking place because of the heartbeat. So inside the Haversian canal, the blood is not transported by our beating heart, but it needs to be supported by flexion. So the bone has to flex a little bit. And in order to come to this flexion, of course, our osteons, the Haversian canals, need to have a specific size. And if the size of these osteonal canals is not adequate to the function, then the only way out is the osteonal remodeling, and in this case, a new osteon is going to be formed, and the canal is going to be wider than the old canal. This also leads to steroid loosening. So the bone doesn't have too many answers to problems. Usually, the answer of the bone is osteonal remodeling. Now, in this picture, it's written window of the acceptable load. So if the load is less than in the underload case, in the overload case, and if it's more than in the underload case, then we have a constant situation. We always have the same amounts of bone. There is not too much bone, and bone is also not resorbed. And this is the stable situation which we want. This is also the stable situation which guarantees the implant integration, a stable implant integration. Keep in mind, again, I want to remind you what I said in the first part. Sooner or later there's going to be a cortical around the bone, and then of course all these things are not so important. Now this brings us to the question of the blood supply. I mentioned that there's a blood supply necessary for woven bone formation. On the next picture you can see that there are blood vessels around the teeth, and this is a dog bone, but it's the same in the human's bone. So we have desmodontal vessels which drain the blood out of the mandible or out of the maxilla towards the mucosa. And of course, if we extract the teeth, the cortical closes over the extraction site, and this blood cannot escape anymore. So therefore, we have a situation where stasis occurs inside, and the stasis leads to atrophy, the stasis leads to dissolving of the bone, and of course the big bone mass, as it has been before, while the teeth were still in function, still in the bone, this big bone mass usually cannot be maintained. So this is one of the main reasons of atrophy. So the desmodontal vessels are draining the jaws. This allows nutrition of larger bone areas. After extraction, the interbony vessels only pass through the bone. They have no nutrition function. So for example, the mandibular artery, when it runs through the mandible and it comes out as the mental artery, as soon as the teeth are extracted, none of the blood is going to be drained out along the desmodontal areas, and of course then this vessel only runs to the bone. It has no other function anymore, and also it calcifies very quickly. Yeah, sometimes I get the question, in which direction are the osteons running? Now the osteons are not running exactly in the direction of the bone, but they kind of travel the spiral around the bone. So it's mentioned in the literature that the progress is with an angle of approximately 12 degrees. And that's why we should forget the idea that, for example, the white line which we see on the mandible, in the corner of the mandible, in the angle here, is like one. It's like one osteon. This osteon is higher mineralized. This is not true. A number of osteons are participating into this white line. So this tells us a part of the osteon can be highly mineralized, and another part of the osteon in a different area is not as highly mineralized. So if we see highly mineralized areas inside the bone, it doesn't mean that this is one highly mineralized osteon. I'm mentioning this for you to understand that if we see highly mineralized areas in the panoramic picture, it doesn't mean that single osteons are affected. Out of traumatology and out of the experiments which were done in the 70s and the 80s of the last centuries, we have a very nice experiment. It's called the ulnar osteotomy experiment. So from those two bones, which you see on the top of the picture, this bone is being cut out, and then as a result you can see that the bone mass of the remaining bone increases. So this tells us if we cut out a piece of bone with the function remaining the same, the bone is going to be replaced, even if, like in this case, it's going to be replaced on a different bone or a different bone site. But simply this bone is needed. Function demands this bone. There's enough function for so much bone. You can also tell it this way around. And we can also expect that the same thing happens in the jawbone, and I want to show you an example for this. Now this patient came to us with a severe atrophy on the left side. There were some teeth on the right side, and of course, this patient was then given a bridge, a symmetrical bridge for symmetrical chewing function on four basal implants. And as you can see, after 18 months, we see an increase of the bone on the left side. So the question is, of course, why does the bone grow? Well, the bone grows because it is needed. Before, I mean, when the patient had those 2-3 teeth on the right side and the removable denture fixed to this, the patient was only chewing on the left side, so there was not a lot of function or almost no function. On the right side, so there was almost no function on the left side. Now, after receiving a symmetrical fixed bridge, we created a situation where the masticatory function was identical on both sides, and in this situation, also the bone must be symmetrical, and it means that bone must grow. This is a bit strange. It is unusual for us implantologists to see this. But in fact, bone will grow if there is a demand for bone. So the same what was happening in this ulnar osteotomy experiment, that bone grew because another bone was cut out. We see in implantology, if we create a symmetrical chewing function and the patient suddenly can chew on both sides. It should be mentioned at this point that, of course, the osteotomy, which takes place here in order to insert the implant, can be like the start point of this bone growth. So it's not only that the bone just grows by itself, but also this kind of lazy situation before the operation has to be changed. So there has to be an incentive. We have to kind of stir up the bone with our implant placement, and then more bone is formed. Keep in mind, however, that in the normal case, typically at the end of a remodeling process, less bone is available than before. I mentioned this in the first part of the lecture. So this, what I'm showing you here, is definitely an exemption. It's an exemption to that rule, and here we have seen the bone formation because the function was strongly increased. Typically, the functional loading increases in patients as soon as they get rid of the dentures. They can chew, they can apply more forces. They don't they are not afraid of pain under the denture, of things coming under the denture, and so on. So the brain finds out very quickly that all these dangers are gone, and the brain then freely starts to chew. There are a few experiments which I would like to mention at the end of this lecture. One experiment describes what happens if young dogs are immobilized. And you see that if young dogs are immobilized, you see a decrease in the bone circumference. So actually the bone becomes smaller. This is due to the hormonal situation of the young animals, and actually we can expect that the same will happen to humans. If old dogs, however, are immobilized, then the outer circumference of the bone remains the same, but the bone shows a kind of osteoporosis from the inside. I mean, we know this from the osteoporotic disease, but I'm mentioning this because we are usually working with patients in older age, let's say 40 plus or 45 plus. So if we would immobilize their bones, then we would see an osteoporosis developing, and also, of course, developing in the jawbone. Keep in mind, however, that the woven bone formation, so the healing capacity, basically is the same in osteoporotic patients as in healthy patients. So osteoporosis is a disease of the osteonal bone system. It has nothing to do with the woven bone system. And well, there's a joke, how do we cure the osteoporosis? And the answer is we just break all the bones of the patient, and then we create a lot of woven bone, only that the patient would not survive the therapy. Well, there is some truth behind this joke, because of course with every fracture we would create a lot of woven bone. This woven bone would then be remodeled, so at the end of the game we would see more osteonal bone, of course. Now, what happens if you train animals? This was shown by Wu et al. Trained pigs. They get an increased compactor volume. This is also what we can expect in humans. Now, often the question is raised: how much load is necessary? I mean, how much do I have to walk to keep my bone mass constant? You know, how much exercise is really necessary? And it was shown in experiments that 4 real cycles of load per day is enough to maintain the bone mass. If you have less than 4 cycles, of course, then the bone mass is going down. You can see this in the red line here. So the bone mass is going down by approximately 15% within 6 weeks or 7 weeks, 42 days. And if you have more cycles of loading, 36, 360,000, 800, of course the bone mass increases, but it doesn't really increase a lot. So this will then come to some adequate level. I mean, the bone mass will be adequate to the loading. This is why the wood choppers, you know, in the woods of Canada, they have very strong bone, but the bone doesn't grow then anymore. I mean, some amount of bone will grow, but it will not be more after half a year or so. Simply this adaptation is then reached. We don't, and those guys, they don't need so much more bone mass. They also need higher mineralizations. They need some stability against the cracks because they chop every day. So this was shown in this experiment. Even if you have a lot of load cycles, the bone mass, the mineral content goes up by 20–30%, but not more. Now let's talk at the end of this lecture a little bit about the fatigue. I gave you this experiment, I gave you the example of this experiment with the untrained soldier syndrome. So the soldiers were kind of carrying the weapons and walking, and their long bones then were fracturing after 6 weeks. So what is the reason, or what is the difference between dead bone and alive bone? If you would make the dead soldier walk, if this would be possible, then this would not happen because the repair process would not take place. Of course, if you make the dead soldier walk, then with every step that this guy takes, there would be a crack. And the cracks, of course, would accumulate because nothing repairs the bone because the guy is dead. So what would happen is that the bone will lose the strength after 1 to 3 million cycles of load, but it would not fail. So it would change into some composite laminate material, and it would become weaker and weaker, but it would not fail. It would fail only after about 30 million cycles. The alive bone breaks after a few thousand cycles, and the reason for this early failure and for the complete failure actually of the long bone is the repair process. So what we are really afraid of as implantologists is the repair process. The bone is very friendly, but the repair is what we don't want, and that's why we are not allowed to overload bone. Of course, on the other hand, we are also not allowed to underload bone. To give you an example, if you would have a piece of glass and you would break it, it would break immediately. I mean, if it reaches a certain amount of force, it would break, and it would break completely in one piece. I mean, you throw the glass and it just breaks. It doesn't just bend a little bit and break later or whatever. It just breaks. And we don't have this situation in bone. In bone, we have a lot of small microcracks, and these microcracks can be repaired if there is enough time to repair it, and of course if there's also enough bone mass to maintain the stability of the bone, but usually the bone doesn't break. Only if, as shown here in frequency number 2, only if the time between 2 microcracks becomes too short, or if the microcracks accumulate, then we come to the untrained soldier syndrome, and finally the bone would fail as such. Now, how can we imagine that the repair takes place? I'm showing you this on the graphic. The debonding here takes place outside of the osteon. So between the 2 osteons in this black line, a slip line develops, and those 2 osteons are not bonded to each other. Now this changes the stress inside the osteon. I mentioned in the first part of the lecture that the osteocytes have possibility to sense this information, I mean mechanical information. Then a new osteon formation would be triggered, you see this here, and finally the new osteon would then repair this deep bonded area. So this is a picture how we can imagine that this takes place. And of course, this can take place in thousands of small areas inside the bone. And here's an histology picture about this. Here you see a crack between the osteons and a crack inside the osteon. So this is how, just to visualize the problem of these microcracks, which can accumulate. I mentioned earlier that this osteonal activation or BMU activation is age dependent. So young individuals don't show a lot of osteonal remodeling. This is because they are growing. You see this here on the left part of the picture, and keep in mind that this is a logarithmic scale. So the vertical scale is logarithmic and the horizontal scale is linear. So we have a lot of osteons forming in young age. And then around 25, 30 years of age, bone becomes very stable. So there's only 1 or 2 osteons per square millimeter of bone per year. So this is fortunate for us implantologists. This is a very stable situation. However, if we place an implant, we are creating this peak in osteonal remodeling. So there's more osteonal remodeling, but of course this is only locally. If we place the implant into the jawbone, of course we will have more osteonal remodeling in this jawbone, but we will have not more osteonal remodeling in all the other bones of our body. So this is a local development, whereas this graph, this black line, is of course affecting all of our bones. So this was the part 2 of this lecture about bone. Thank you very much for your attention.